Just a second there, sorry. Okay, so thanks, Elizabeth, for having me here today. I've been asked to cover the topic of some insurance coverage, or mostly focusing on the diabetic patient population. So first off, just to have no financial disclosures here for this presentation, any mention of brand names just for identification purposes only. So the objectives of this talk is going to be to review some resources that are available for determining coverage for our patients. And then we will discuss some specific medications that often require prior authorizations. And I'll try to provide some guidance and tips on how to increase the likelihood of getting a favorable outcome with those prior authorizations. So first of all, just a little bit about the numbers. Diabetes is a very expensive condition to treat. A lot of that reason is because there's been an explosion of patients who have diabetes, not just in the US, but worldwide. And also a contributing factor that is with the increase in numbers, there's been a lot of research and a lot of development in diabetes, and that means new medications, and new medications tend to be expensive. So you can see here, for every $7 spent on healthcare in the US, $1 goes towards the treatment of diabetes and its complications. So it's very expensive to treat. And like I mentioned, there's been a bit of an explosion of patients diagnosed with diabetes in the US. And this is a trend that's also seen worldwide too. And it's not just treating diabetes. We have to think about the patient as a whole and the complications that come along with diabetes, which are also a large burden financially to the health system. You can see here in terms of cost of treating diabetes. So this is outside of insulin in the red box here, other anti-diabetes agents. The average cost of it there is pretty high. And then other prescriptions total in these patients also very significant. So with the limited resources that we have to treat these patients, it's important that we're using those resources responsibly. And that's something insurance companies try to do. One of the ways they do that is by putting prior authorizations in place to make sure that the right patients are getting the medications, which the process can be a little bit cumbersome, and sometimes it seems like they're just putting up roadblocks, but it's their way of making sure that they are spending the limited resources that they have appropriately. So in terms of trying to determine what medications might be covered by your patients, there's a few things out there that can help us. This one app that you can download on your phone from either the Apple Store or Google Play is called the Coverage Search app. You can see a little screenshot of it here over on the right. You can put in the medication that you're looking for, the state you're in, and what type of insurance, if it's commercial or Medicare or Medicaid, and it will give you some guidance based on the plans, whether it's a preferred agent or if it requires a prior authorization or step therapy or things like that. This is a pretty up-to-date app. It is a third party, so it may not be always up to date, but most of the time it is pretty accurate. But don't take it for being written in stone if this tells you it's covered and doesn't require prior authorization. They're pretty good about updating it, but again, it's third party and things change rapidly, so keep that in mind. Another thing I want to talk to you guys about today is this NovoCare Obesity Cost Navigator. So this is not specific to diabetic patients, but for weight loss medications. Novo has this application here where you can go online and put in some patient information, and it'll tell you whether the prescription requires a prior authorization, and also give you an estimated cost on the medication. So it's a pretty good tool to use. It is only for Saxenda or Wegovy, but if you are considering those medications in your patients, this might be worth checking out before you go down the prior authorization rabbit hole. It's pretty easy to use. You just select what medication you want to use, and you can enter in patient information, just their name, date of birth, gender, and zip code. And then you do have to have a provider registered with an MPI. And when you're registering this, you have to use the email that you used when you first got your MPI. So even if you've updated your email since you've gotten your MPI, you have to try to think back of what email you were using when you originally got an MPI and use that to register for this portal. So keep that in mind. And once you enter the information here for which medication and the patient, you select which pharmacy. It doesn't always matter which pharmacy you're putting, but you can just put the patient's preferred pharmacy, or if it's a specialty medication, you can enter the specialty pharmacy, whether that's CVS or Allied or whoever. and it gives you some guidance on whether or not it'll require a prior authorization. So for this patient, if we wanted to start them on Wegovy, it does require a prior authorization, and the estimated cost would be about $70. And then from this website here, if you click the Get Started button, it'll take you right to Cover My Meds and start the prior authorization for you. So this could be a good tool if you're considering starting either Saxenda or Wegovy in some of your patients to sort of help out and give some guidance on what's required to get those started. Some other good programs that are out there, GoodRx, most people are probably pretty familiar with. And then there's other foundations such as the HealthWell Foundation, which is one that we've had some success using in the past. This HealthWell Foundation is nice because it's disease state specific, not medication specific. So if there's a fund open for treating hyperlipidemia, the funds that the patients get aren't tied to a certain medication. So that makes it nice. You can pick the medication that you think is appropriate for the patient, and then the fund will provide either copay assistance or whatever they're available to help out with there. So this is what that HealthWell Foundation kind of looks like. It tells you some information about what the maximum amount they'll pay for, if there's minimum copays, and then some of the guidance on who qualifies for each program. So with this one, with the HealthWell, each disease state has its different qualifications. So for this one, for hypercholesterolemia, it's 500% of the federal poverty level to apply for this. And as you can see here on the right, treatments covered. It's a whole variety of medications. It's not tied to one specific medication, which is pretty nice. And I think there is our mentioned on this page over here. Yeah, there's over 80 different disease states that this HealthWell Foundation has funds for. As long as they have funds, the fund will be open. And when the funds are depleted, they will close the fund and then you're not able to apply anymore. And you just have to keep an eye on it for when they get more funding and reopen the fund. In terms of Medicaid coverage, I put some links here just for your own information. If you click the links, it'll bring you to each state's respective preferred drug list for Medicaid, which can be a good place to go if you're looking to find information on what is a preferred medication in your state. So if you click the links, I'll just go quickly through this here as an example. It'll take you to this website for West Virginia, and you can scroll down. You can see this was updated in October. So if you click that link here, it'll bring you to this list for medications, and you can just use your control find function to find the class of medications that you're looking for. And you can see here for hypoglycemics, if we search GLP, they'll give us the preferred agents being Ozempic, Trulicity, and Victoza. So those are going to be the preferred agents for these patients in West Virginia. And then it also lists the non-preferred agents and gives you some guidance on what is required for authorizations of these medications in here. So this can be a pretty useful tool. And again, this is updated regularly. This was updated in October just to include Mounjaro here in the list of non-preferred agents for this. So good place to go if you're trying to figure out what's covered for your patients. In terms of SGLT2, so common medications in the diabetic population here, I put this little table together for some guidance on the individual states for Invokana, Farxiga, and Jardiance. They're all preferred in West Virginia and mostly preferred in the other states. You'll see some requirements in those where there's step therapy or some of them have quantity limits also, but they're pretty good coverage across the area that we see patients from here at WVU at least. And there are savings programs available for these patients. Generally, if you're on Medicare and Medicaid, you do not qualify for these savings programs. So it is usually for commercial patients only, but they are available for all the SGLT2s that we commonly use. And the links here will take you to those sites respectively if you want to apply for those for patients. And then again, in terms of GLP coverage, here in West Virginia and most of the other states, Trulicity is a preferred agent. So that's usually going to be a go-to. That doesn't mean you can't use the other ones. You did see for Medicaid, Ozempic and Victoza are also preferred in West Virginia. So depending on the patient, for Medicare also, you could use the other agents, but Trulicity seems to be the one that has the best coverage in terms of Medicaid patients in the area. And again, similarly, there are copay savings cards available for commercial patients for these medications also. And the Novo Care Foundation one here, that can be used for any of the Novo product. So it's not specific to Victoza, but it could be used for the other products also. So when we're trying to do prior authorizations, I find one of the most important things to keep in mind is that we're selecting the proper indication. That can be sometimes the biggest hurdle. That's usually a quick fix when we have a denial. So when it comes to indications for the GLP-1s, they are not all equal. So Trulicity is unique because it has the indication for reduction of cardiovascular events in primary care patients. So those that have not had a previous event. So that's what's unique about Trulicity. It is indicated for reducing the risk of MACE in patients that haven't had an event. And that's because when they did their rewind trial for their cardiovascular outcomes, they had a baseline population that was 60% primary prevention. The other trials, so Sustain 6 and Leader for liraglutide, those were mostly secondary prevention populations. They only had 30% primary in the Sustain trial and 20% in the Leader trial. So the FDA wasn't comfortable giving them that indication for reducing events in patients that had not had a previous event. Whereas in Trulicity, because they had 60% of patients that were primary prevention, they did feel comfortable. So it's not that Ozempic and Victoza don't work in reducing events in those patients. It's just that they don't have as robust data as Trulicity did to get that FDA indication. So that's one thing to keep in mind. And I think that's probably why Trulicity has become a preferred agent for a lot of the states, because it does have that indication. And then for those of us that do treat pediatric patients, Victoza does have some data for younger patients. So it is approved for 10 years and older with type 2 diabetes, which is unique for that. So I think a lot of the times we just keep an eye on what indication we're selecting. It can really help increase our chances of getting these medications approved. Another thing I wanted to highlight was sort of an update in the guidelines recently. So the ADA guidelines have sort of changed what their first line therapy is. They've changed the wording of it to include first line therapy that depends on comorbidities and is patient-centered, including cost and access considerations, and management needs to be generally or is needed, and generally includes metformin and comprehensive lifestyle. So that's a bit of a change where first line therapy was lifestyle and metformin. Now it's saying it generally includes metformin and lifestyle, but based on comorbidities, you can use other agents. So that I think opens the door for us to be using SGLT2 inhibitors and GLP-1 receptor agonists as first line therapy based on comorbidity in patients. So hopefully insurance companies open the door a little bit more to that and sort of take down some of the roadblocks in using it in these patients. And that's echoed again by the ACE recommendations, where they recommend independent of glycemic control. If you're at high risk for ASCVD or CKD, you should be on either SGLT2 or GLP-1 that has been shown to reduce the risk of progression. So even if they are at A1C target, we should be considering using these agents to reduce the risk of cardiovascular events or CKD progression. Also, when it comes to reducing the risk of cardiovascular events, a lot of our patients qualify for use of PCSK9 inhibitors. Based on the FDA-approved indications, they are approved for secondary prevention or primary prevention with primary hyperlipidemia, which includes heterozygous familial hypercholesterolemia or homozygous familial hypercholesterolemia. So that's for both Praluent and Repatha. Repatha also has the indication for pediatric patients, age 10 and older. So if you are seeing pediatric patients, Repatha might be the preferred option for you. In terms of the guideline recommendations and where they come into therapy, the ADA recommends it for secondary prevention if you're on a statin and your LDL is still not below 70, as well as the ACE if you're on maximally tolerated statin and not below threshold. So ACE is a little bit different. They use these LDL thresholds. So for our diabetic patients, as long as you have one or more risk factor, you're going to be at a very high risk category, which puts your LDL threshold at less than 70. So they are getting pretty aggressive with LDL thresholds these days. If you've had a previous event plus diabetes, your threshold is 55. So with these new agents that we have available to us, these thresholds are getting pretty aggressive, and we're seeing lower and lower LDL targets. So a lot of times we see patients and we're used to seeing very high LDLs, maybe in the mid 100s, 150s, and we think maybe 110 or 120 is okay, but the guidelines are recommended that we get pretty aggressive here and we start targeting lower and lower LDL thresholds. So that's where these PCSK9 inhibitors might come into play. And in terms of getting these approved, again, I think picking the proper indication is very important. there's been a few things where we noticed insurance is pushed back. If it's managed by, I believe it's Express Scripts, they are requiring coronary artery calcium scores of greater than 300 Agaston units. It doesn't matter if they have statin intolerance or are not at LDL threshold that's recommended. They are really hanging their hat on this coronary artery calcium score. So they do require that for patients to be greater than 300 for coverage, which has been a bit of a roadblock for a lot of our patients. Another thing we can do to help improve likelihood of it being approved is determining whether or not patients have heterozygous familial hypercholesterolemia. So to do that, we can use this Dutch lipid score calculator, which is an easy tool to use. Generally, it's going to be for patients that have had LDLs greater than 190, and this can be untreated. So if you don't know what their baseline LDL is because they've been on high intensity statin therapy and you don't have any lab work from before that, you can estimate it. So a high intensity statin would be expected to lower LDL by at least 50% or more. So if they're on Lipitor 40 and their LDL is still 130, you can expect that it would certainly be above 190 at baseline. So when you're using this lipid score calculator, it is untreated LDL that we're using here. And when you use the score calculator, if you get a score of at least 6, that's probable familial hypercholesterolemia. And most insurance companies, that's what the threshold they use for covering these agents is. And some things you can do to improve or to further support the diagnosis of familial hypercholesterolemia is to screen patients for things like tendon xanthomatas, so these cholesterol deposits in the Achilles tendon or in the hands here, or arcus cornealis, this gray bluish ridge around the circle, which is another sign of hypercholesterolemia. So if you're seeing patients and you're considering starting a PCSK9 inhibitor, if you can just sort of keep an eye out for those and document it in your notes, it can improve the chance that the insurance companies will approve the prior authorization. Another one here that I think, again, it's important to select the right indication when doing prior auths is for Vascepa. So Vascepa is a purified EPA. It does not include any DHA, which is what makes it different from the over-the-counter agents. It does have 2 approved indications. So the one is to reduce triglycerides in patients with hypertriglyceridemia, defined as triglycerides over 500. Excuse me. But what we're most commonly using it for here in diabetic patients is actually to reduce the risk of cardiovascular events in patients with diabetes who have triglycerides over 150 while on statin therapy. So it is a separate indication. If you select that you're using it to treat hypertriglyceridemia and your patient's triglycerides are only 175, there's a strong chance that's going to be denied because the hypertriglyceridemia indication requires triglycerides to be over 500. So keeping that in mind when we're filling out the prior authorizations forms is really important. Along with this, there is a generic available, but there's a court decision that sort of decided that Vascepa is the only one that is FDA approved for reduction of cardiovascular risk. So the generic is available, but technically it only has the one indication approved by the FDA for treatment of hypertriglyceridemia. So if you do want Vascepa, you do have to write it for brand medically necessary on your prescriptions. And I want to talk a little bit about step therapy. So step therapy, a lot of the times in these insurance companies, they require them to be on maximally tolerated statin, and that can be no statin. So if a patient has tried at least 2 other statins and they don't tolerate it, it is appropriate for them to be on no statin and try some of these other medications. So they don't have to be on statins when they're using the terms maximally tolerated statin. And it's also important to keep in mind that usually a lot of plans require trials of high intensity statins. So high dose does not equal high intensity. So a simvastatin 40 or even 80 milligram, although it's high dose, that does not count as a high intensity statin. So for high intensity statins, we do need to be using Lipitor or Crestor. Another thing that's important with these statins is the insurance companies do have claim data based on when patients pick up the prescriptions. So they can look into whether or not the patients have actually picked up a prescription. So sometimes a prescription might be sent for Crestor, but the patient never picked it up and never started it. So when you submit the prior authorization, the insurance company knows that they never picked up the Crestor, whereas the providers might not have that information. So it is important to make sure that the patients are actually picking up the medication. So if we have evidence that they have tried the medication, they've had a trial of it, either didn't tolerate it or still not at threshold. So sometimes that's a roadblock where Providers are assuming the patients are taking the medication, but the insurance has some information that they don't. So we need to check on the claims data to make sure the patients are actually picking it up. I just like to mention this medication here because it is a bit of a newer medication that is available for these patients, which does require prior authorization. Nexletol or bempedoic acid. So it's a novel mechanism for a drug. It's actually a prodrug that gets activated in the liver. So it's not activated in the muscle tissue. So although it works in the same pathway as statins in the cholesterol production pathway, it's a couple of steps upstream. But because it doesn't get activated in the muscle, we are expecting to see less myalgias and myopathies with this medication. So for those patients that are statin intolerant or still not at thresholds, it may be a viable option to try this medication. And one of the benefits about it is that it comes in a combination product with ezetimibe. So if your patient's already on Zetia and you want to try this medication, you can switch them to the Nexlizet, which is a combination. And you're not increasing pill burden, or they're not having to pay an extra copay because it is a combination product that is available on the market. So could be an attractive option for some patients that are not at threshold yet. And it is currently indicated for those with familial hypercholesterolemia or who have had an event. So not for primary prevention yet, but there are copay cards available for those to pay as little as $10 for a 3-month supply. Again, that'll be for commercially insured patients only, not Medicare or Medicaid. Just a little bit more about bempedoic acid. Just use this as an example of how to find out what the requirements are for a PA for Medicaid. So for West Virginia, as an example, if you go to their preferred drug list website, like that we were at before, and look up what their PA requirements are for their criteria, they have a list of all the medications that require PAs here. If you find the medication that you're looking for and you click it, they'll give you really specific information that's required. So for West Virginia Medicaid patients to be on Nexletol or Nexlizet, they have to meet age requirements. So it is only approved for adults. And then it gives you the additional information that's required here. So those that aren't at LDL less than 70 after an 8-week trial of atorvastatin and ezetimibe, or rosuvastatin and ezetimibe. And the nice thing about this is it also gives you information about what continued coverage would require. So their initial coverage would be for 90 days. But then after that, you have to show evidence of at least a 10% reduction in LDL before the continued treatment. So if you're looking to see if your Medicaid patients would be able to be covered for these products, that's a good place to go, is the preferred drug list. And they can give you a lot of good information there. And that's directly from the website, just screenshotted there. One of the newer medications a lot of us are probably familiar with now is tirzepatide. So insurance coverage is improving for that. It is available for a lot of commercial patients so far. We did see earlier that it was added as a non-preferred agent for Medicaid patients in West Virginia, at least, but there is a savings card available for this for commercially insured patients. So if you go to the website here, you can download it, the savings card, and then print it out and hand it to the patients, or they can go from their phones and go to this website and get these copay savings cards for a $25 for either a 1 month or 3 month supply, whatever you write the prescription for. So for commercially insured patients, this could be a good option for getting those started on the new Mounjaro medication that is available. And also for this, so it is only approved right now for type 2 diabetes, but the FDA did grant it fast track status for its weight loss indication. So not currently approved for weight loss yet, but that is likely coming in the near future. And then it's something I wanted to update you guys on. Recently, the news came out about this Inflation Reduction Act. So there is some things within this bill about cost of medications that are pretty exciting. So starting January 1st, as written in this bill, for those on Medicare, a month supply of insulin will be capped at $35. So they did try to get this passed for Medicare and Medicaid patients, but that bill did not pass. So as it currently stands, it is only Medicare patients, but that's pretty exciting that as of January 1st, the price of insulin will be capped at $35. And then starting July 2023, that'll also apply to those that get their insulins under Part B, so those patients that are on pumps. So starting next year, pretty soon, a lot of patients will probably see a pretty dramatic drop in the price of their insulin, which is really exciting to see. So starting in January for those that are on injectable insulin, and starting in July for those that are on pumps, $35 for a month supply. Also written in with this act, just a couple other things. In 2025, the Medicare Part D max out-of-pocket cost will be dropped to $2,000. So that will help out a lot of our patients. And it sounds like they're also getting rid of the coverage gap in 2024. So once you go into the catastrophic part of your coverage, you will have no co-insurance or co-payments to make. So if you want some more information on what else is in this Inflation Reduction Act as it applies to medication coverage, there's a link here for you to go to, which has a timeline set out for when all these things come into play. But good news on the horizon for a lot of our patients, which will make their medications a lot more affordable. Any questions?
Thank you so much, Hugh. That was wonderful. Really great advice, help, resources. I had a quick question. Is the NovaCare site, is that just for pharmacists or doctors to utilize, or can patients use that type of link?
You do need an MPI. So when you go to the website, it'll ask you if you're a patient or a provider. And to get to that coverage part, you'd have to do the healthcare provider site. And then anybody with an MPI can register. So I myself as a PharmD is registered, but as long as you have an MPI, you can register.
Okay, excellent. Good to know. Sometimes I feel like when we're trying to figure it out on our own, I have to go through so many different avenues and try to find out what's covered.
And it used to just be saxendacoverage.com. So if you Google that, it'll come up. But now with Wegovy on the market, it does both Saxenda and Wegovy.
Awesome. Yeah, just it's kind of crazy how much diabetes, like you said, it was just really rising and the trend is going higher and higher. Do you think that's because we have better testing or more individuals are getting tested now? Or do you believe it's just our health and our habits? This is for everyone to talk about. I just didn't know why we're seeing such a continuous rise in diabetes.
I do think it's a bit of both. I think we are getting better at screening. I don't know if my picture here showed it, but the gap between undiagnosed and diagnosed patients. So this data is a little old, 2516, but this gap between undiagnosed and total patients does seem to be closing. So we are getting better at screening, but I think overall it's just a widespread in terms of lifestyle, eating habits, a whole multifactorial thing that's leading to the substantial rise in diabetes.
Absolutely. Thank you. Does anybody else have any comments or questions they would like to add?
I'd like to ask about access to 340B, pharmacies within West Virginia anyway. Can you speak to that, Hugh?
Yeah, so we do have many contracted pharmacies that are able to dispense under the 340B program. I don't have the list off the top of my head of what those are, but I can get that for you if you'd like. And I know specifically the Med Center pharmacy here that's located within Ruby Memorial Hospital is one. But I know also even the Kroger down the hill from us here is also a contracted 340B program. So as long as the pharmacy is contracted with WVU, you should be able to access the 340B pricing.
We have a 340B pharmacy within our organization over here. And I'm surprised at times that more folks haven't checked their eligibility, because many do, and it creates such an improvement in our access to some of the, especially the SGLT2s, which otherwise are beyond their comfort zone cost-wise.
Yeah, there can be a really high cost associated with those. So the programs are able to carve in or carve out what they include in their 340B pricing, but I think a lot of them are choosing to put these diabetes medications in there now to take advantage of that. The issue is they have to keep separate inventory for it, and there's a whole bunch of rules for it, which can be a little bit cumbersome, but I think the financial benefit both to the institution and the patient is becoming pretty evident, and more places are moving towards 340B utilization.
Thank you so much. Do you have any further questions, Janet? Please feel free.
Yeah, I do wonder if there are folks in non-rural areas that are eligible for 340B, but their primary care practice isn't channeling them to 340B contracted pharmacies. Is there anything we can do about improving their access?
I think just spreading awareness would be a big thing. So the cover entity that they're being seen by, I believe, also has to be covered by 340B covering entity. So as long as they're a WVU institution, I think they do qualify. But I think just spreading awareness to those providers about 340B access and that it is available is a big thing.
Thank you.
Excellent. Thank you so much. Any other comments or questions? All right. Excellent. Dr. Giordano, do you mind sticking around after we close to the session today for a
No,
moment? We have
fine.